For people outside of the medical profession, a hospital or doctor's office can be an intimidating place. The job of making a patient feel comforted and cared for often falls on the shoulders of the nurses. To best meet the needs of a patient, nurses must learn the principles of therapeutic communication, which is defined as communication strategies that support a patient's feeling of well-being. This term is easy to recall if you remember that something that is therapeutic is done to help a person cope with the situation and ultimately feel happier and more relaxed. The goals of therapeutic communication are to help a patient feel cared for and understood and establish a relationship in which the patient feels free to express any concerns. In this lesson, we'll explore the different types and principles of therapeutic communication. Did you ever play a game of charades? If you did, you know that the object of the game is to convey meaning without using words. Without words, you need to rely on things like facial expressions, body language, and eye contact. Like a player in a game of charades, a nurse must be aware of his or her own nonverbal or non-spoken communication style. For example, if a nurse does not make eye contact with a patient who is describing a symptom or leans on a desk with her arms crossed, the patient may feel that the nurse is not interested in what they have to say. In contrast, a comforting touch on the arm from a nurse who is leaning toward the patient and making eye contact may help a patient feel like her concerns are being heard. A nurse must also be able to pick up on nonverbal cues from the patient. A patient who appears to be tense, will not make eye contact, or who paces on the floor may have a concern or comment they are afraid to share. Observations of these nonverbal cues can be used to strengthen verbal or spoken communication with a patient. With effective verbal communication, a patient's thoughts, feelings, beliefs, values, and perceptions can be conveyed. There are different principles and techniques that can be employed to ensure effective therapeutic communication between a nurse and patient. For example, using silence requires discipline on the nurse's part, but gives the patient time to process what they are hearing and formulate any questions they might have. Providing broad openings by saying things like, "What can I help you with today?" gives the patient an opportunity to share what's on their mind. Offering general leads, such as, "Yes, I see, please go on," leave a patient with a sense that they are getting their point across. Making observations about nonverbal cues that a patient is displaying can open lines of communication. For example, if a nurse observes a patient pacing the floor, she can say, "I notice you're pacing. How are you feeling today?" Paraphrasing the patient's own words gives the patient a sense that they are understood. For example, if a patient says, "I sometimes feel confused, and last evening I couldn't remember my daughter's name," the nurse could reply, "You're having difficulty remembering things." A nurse can also lower a patient's anxiety and provide a safe environment by clarifying information and sharing empathy with statements such as, "It must be frustrating to not be able to recall certain things." And we shouldn't forget that a nurse can lighten the atmosphere by using humor, which promotes a feeling of peace and friendship. Let's review. Therapeutic communication is defined as communication strategies that support a patient's feeling of well-being. The goals of therapeutic communication are to help a patient feel cared for and understood, and establish a relationship in which the patient feels free to express any concerns. Therapeutic communication can be either verbal, meaning spoken, or nonverbal. With nonverbal communication, a nurse needs to rely on things like facial expressions, body language, and eye contact. There are different principles and techniques that can be employed to ensure effective therapeutic communication between a nurse and patient. Some examples include using silence, providing broad openings, offering general leads, making observations, paraphrasing, clarifying information, sharing empathy, and using humor. Even as small children, we learn that friends make the world feel safe and fun. True friends are trusted with our secrets and respect our privacy. Through their actions and words, Friends encourage us to reach our goals and comfort us when we have a setback. In a lot of ways, a therapeutic nurse-patient relationship is like a friendship. This professional interaction is a caring relationship that supports a patient's well-being. A successful nurse-patient relationship is based on trust and respect, much like a friendship. In this lesson, we'll look at these components and others and show how they can be used to help a patient move through the different phases of a therapeutic nurse-patient relationship. There are many skills to learn when studying to become a nurse. One of the most important skills is how to create a therapeutic relationship with patients. To do this, a nurse must master a few key components, including trust and respect. As a nurse, you should introduce yourself to your patients and refer to the patient by name. These seemingly small gestures display an air of friendliness, caring, and approachability, which can go a long way toward making a patient feel safe. When you maintain eye contact with a patient, you continue to foster trust and respect as your relationship progresses. It's also important to respect a patient's boundaries. Some patients feel comforted when their hand is held or they are offered a hug, while other patients may find these actions uncomfortable. Always respect differences in personality and cultures. Showing a genuine interest in the patient's life and situation is another way to encourage a therapeutic nurse-patient relationship. This can be accomplished by taking a few minutes to build rapport with a patient. It's also supported when you actively listen to a patient. For example, a nurse might say, "Jane, you mentioned that you're feeling concerned about what the lab test might reveal." By restating a patient's statement, you reassure her that her concerns have been heard and that you are interested in her well-being. Empathy is another component that is essential to a therapeutic nurse-patient relationship. When a nurse shows empathy, she demonstrates that she understands a patient's feelings. To effectively show empathy, a nurse must be able to pick up on verbal and nonverbal cues shared by the patient. For example, if a patient is pacing the floor after learning that her cancer has spread, a nurse might say, "Jane, I see you're tense. How can I help you?" Displaying these components helps a patient work through their issues and successfully moves them through the three phases of a therapeutic nurse-patient relationship, which are the orientation phase, the working phase, and the termination phase. Yet, even before the nurse and patient meet, we could say that there is a pre-interaction phase. In this phase, the nurse must become aware of her own personal feelings, fears, and worries about working with a patient. This self-awareness allows a nurse to accept a patient's differences without judgment. The orientation phase is the period when the nurse and patient first meet and goals are set. The goal of the orientation phase is to build trust and respect. During this phase, the rules and limitations of the relationship are communicated through pleasant greetings, eye contact, and mindfulness of the patient's boundaries. It's during the orientation phase that the nurse attempts to discover why the patient is seeking help and what their goals are. Displaying a genuine interest in the patient and showing empathy can help during this information gathering phase. The working phase is the period when solutions are explored, tried, and evaluated. The goal of the working phase is to promote change. Now, if you've ever been faced with change in your own life, you know that it can be uncomfortable. Because of this inherent discomfort, we see that the working phase can stir up some resistance on the part of the patient. The nurse must expect this behavior and be aware of the verbal and nonverbal cues being displayed by the patient. The nurse can then guide the patient through this phase by actively listening to concerns and helping the patient to develop coping skills. When a safe and comfortable working environment is achieved, treatment can move forward on the established timeline. The termination phase is the final phase and the period when a patient's goals are assessed and the relationship comes to an end. As you may know from personal experience, the ending of a relationship can be difficult and filled with emotions. The termination of a therapeutic nurse-patient relationship can also be challenging. The patient may feel a level of anxiety as they move away from the supportive relationship. A nurse must be aware of the patient's emotions, yet firm in her communication. Because the goal of the termination phase is to foster independence on the part of the patient, the nurse should be caring but clear in declaring the end of the relationship. The nurse should not promise the patient that their relationship will continue or give the patient their personal contact information. The desired outcome of the therapeutic nurse-patient relationship has been met when the patient's function has improved, she develops independence, and she feels comfortable making her own decisions. Let's review. A therapeutic nurse-patient relationship is a caring relationship that supports a patient's well-being. Key components needed to develop a therapeutic relationship include trust, respect, showing a genuine interest, and empathy. Following a pre-interaction phase, which is when the nurse must become aware of her own personal feelings, fears, and worries about working with a patient, there's an orientation phase. The orientation phase is the period when the nurse and patients first meet and goals are set. The goal of the orientation phase is to build trust and respect. Next comes the working phase, which is the period when solutions are explored, tried, and evaluated. The goal of the working phase is to promote change. The termination phase is the final phase in the period when a patient's goals are assessed and the relationship comes to an end. The goal of the termination phase is to foster independence on the part of the patient. Desired outcome of the therapeutic nurse-patient relationship has been met when the patient's function has improved, she develops independence, and she feels comfortable making her own decisions.
You're about to enter into one of the most respected professions there is. You, as a nurse, will be pretty much Superman or Superwoman. You'll be tasked with everything from administering treatments to patients, to cleaning up any messes they make, to acting as a quasi-psychotherapist to a patient when they have no one else to talk to late one night but you. But one of the most important roles you'll have is client or patient education before, during, and even after their visit to or stay at the hospital. This lesson covers the purposes of client education, its important assumptions, and commonly covered topics. I guess we need to start with the basics here first. Why bother educating a patient? Why not just tell them that the major deity, MD, knows everything? Why not just tell them that they should just sit still, take it like a man, and things will be fine? It's laughable to think that way since I know you know better. We educate clients for more than one reason. Clients need to know what choices and options they have with respect to a disease process so they're not stressed out about being in the dark. They need to know what risks are involved in a diagnostic or treatment procedure so they can make informed decisions about their own care. They should understand what their chances of survival are or the possible consequences of their disease are so they can face whatever it is they need to with an open yet well-informed mind. Look, it really all boils down to this. One of the most important purposes of patient education is to help patients achieve the best state of health possible through their own actions. Teaching is what gives clients information. That information informs them about health-promoting options and behaviors. Ergo, lack of that knowledge can hinder a patient's ability to help themselves, self-care, while you and the doctor try to help them as well. Other very important reasons we educate clients is to prevent disease or injury, promote wellness, restore their health, and help patients cope. Your job as a nurse and teacher is to bridge the gap between what a patient knows and what a patient needs to know. So now you know what your purpose is with respect to teaching and what the purposes of client education are in general. Let's move on to several assumptions related to adult learners that you, the nurse, can use in your client education. These are not my assumptions, by the way, but were developed by educator Malcolm Knowles. Assumption number 1. A person's personality progresses in an orderly fashion from a dependent to an independent one. What does this mean to you? This means you should plan teaching activities that get a client to participate in the activity along with you in order to develop their independence. This is important because it gives a client a sense of control and thus encourages self-care via empowerment. Assumption number 2. A person's readiness to learn is affected by sociocultural factors and their developmental stage. What does this mean to the nurse educator? Before you develop or plan a teaching learning activity, make sure to conduct a thorough psychosocial assessment of the client, one that may reveal to you that you need to take a different approach with them than when compared to another individual. Assumption number 3. A person's previous learning experiences can be used as a stepping stone for new knowledge and further learning. This means you should assess the client prior to starting any learning activity in order to figure out what they already know so that you can build on that. And we don't want to bore clientele with things they are already well aware of. You need to concentrate your and their time and patience on newer knowledge. Assumption number 4. Learning is reinforced through immediacy. That means you should immediately provide an opportunity for the patient to apply the skills and knowledge they just gained. Alright, so now you know some important basics related to client education. Now, for the more fun part, what kinds of topics are going to be important for clientele to learn? There are 4 main categories for this. The first one is health promotion. So you can teach clientele proper nutrition, how to exercise correctly, how to plan for a family, and appropriate parenting skills. The second category is the prevention of injury and disease. Here, you can educate clients about vaccinations, aka immunizations, the importance of screening for a disease, breast self-exams, why and how someone should stop smoking, and when and why safety devices like car seats should be used. The third one is health restoration. This is where you'd provide information about the treatment methods being used, or you may provide information on the medication they are taking. The final major category is coping. Topics include stress management, counseling opportunities for grief, anger, and the like, information that explains the entire disease process for the patient, and information that explains how a patient should use medical equipment in a safe and responsible manner if they need to do so. Well, we need to summarize this lesson. Remember, one of the most important purposes of patient education is to help patients achieve the best state of health possible through their own actions. Your job as a nurse and teacher is to bridge the gap between what a patient knows and what a patient needs to know. When educating clientele, remember 4 important assumptions related to adult learning. A person's personality progresses in an orderly fashion from a dependent to an independent one. A person's readiness to learn is affected by socio-cultural factors and their developmental stage. A person's previous learning experiences can be used as a stepping stone for new knowledge and further learning. And finally, learning is reinforced through immediacy. Finally, there are a ton of different topics you'll be tasked with educating clients about. They include 4 major categories of topics: health promotion, the prevention of injury and disease, health restoration, and coping. When educating anyone, especially a client, about their medical care, there are several principles that should be practiced. These principles, once mastered, will allow you to become a really effective educator. And believe me, having gone through this myself with clientele, there is nothing more satisfying and more trustworthy to a client than a medical practitioner who is able to educate them well about any given topic. Let's start with the first 3 principles. They are relevance, motivation, and readiness. By relevance, I mean the material being presented to the client needs to be meaningful to them, easily understood by them, and related to information they already know. It's not hard to understand why either. I mean, if you start teaching a client about things like athlete's foot when they are undergoing rehabilitation as a result of a broken arm, that's not all that meaningful, is it? You'll lose and confuse clients if you do something like this. When teaching the information, make sure it's easily understood. What does this mean? First and foremost, avoid the use of big words. You may know what opsablepsia means, but 99.9% of people in the world do not. Actually, I bet you have no idea what opsablepsia means because it's such a rarely used term even in the medical community. See? You got confused when I was trying to teach you with big words. Now you know how a client would feel in the same situation. Another key principle of learning is motivation. Make learning fun, interesting, engaging, and of value to the client. The last thing is probably the most important one. If a client sees the value of learning the information, they can motivate themselves to pay attention and absorb the information. Motivation is closely related to the principles of readiness, a state of being willing and able to learn. This may mean they are psychologically ready and motivated, or it may mean they are emotionally or even physically ready. Next up is the principle of maturation, a state of being physically, cognitively, and developmentally able to learn the required information or task at hand. This means that people with special needs, the very young and the elderly, may not be in the same mental or physical frame of mind as a sprightly 20-year-old. Other lessons will point out ways on how to deal with different levels of maturation. Another principle is one we are all familiar with: reinforcement, the strengthening of knowledge and skills. This involves not only repetition in many cases, but immediate positive feedback to stimulate a person to not only learn, but appreciate what it is they are learning. Reinforcement is very closely related to participation, the active involvement in the process of learning in order to promote learning and retention. It's one thing to listen to someone lecture about how to do something, like dress themselves after a major operation that limits mobility. It's something totally different to actually try and do it. Participation reinforces the concepts a nurse tries to relay to a person in far more powerful ways than just traditional didactic strategies. And finally, the last two key principles of learning are organization and repetition. Organization means that presented material should include previously learned knowledge, build a foundation for future knowledge and skill sets, and be presented in a simple to complex sequence. Finally, there's repetition, the reinforcement of theoretical and practical knowledge and skills through practice. Not just practice, but repetitive practice, of course. Repeat, repeat, repeat. And don't just repeat in the same way either. Presentation and repetition of the material in different ways is key to allowing people to fully comprehend a set of theoretical and practical knowledge without getting bored. Just as one simple example we can all relate to, if you're trying to teach your best friend how to cook, you're not just going to have them repeat cooking the same dish every time, are you? That doesn't master cooking. That masters cooking one dish. Instead, have them cook different meals every time. They're still mastering cooking, but from different angles. So, the 8 principles of learning we went over were: relevance, the material being presented to the client needs to be meaningful to them, easily understood by them, and related to information they already know. Motivation, make learning fun, interesting, engaging, and of value to the client. Readiness, a state of being willing and able to learn. Maturation, a state of being physically, cognitively, and developmentally able to learn the required information or task at hand. Reinforcement, the strengthening of knowledge and skills. Participation, the active involvement in the process of learning in order to promote learning and retention. Organization means that presented material should include previously learned knowledge, build a foundation for future knowledge and skill sets, and be presented in a simple to complex sequence. And finally, repetition, the reinforcement of theoretical and practical knowledge and skills through practice. Although you may be the best teacher in the world, giving out the best information, that doesn't mean your students are going to learn what is expected of them. In this scenario, it's not the teacher that's the problem, and it's not the information itself. Something else is hindering a person's ability to learn. We'll go over several key barriers to learning you will encounter while educating. Being aware of these barriers will ensure your patients get the best education possible. This lesson will also explore the 3 major domains of learning. Receiving information doesn't guarantee learning. That's because external barriers to learning, such as environmental and sociocultural factors, as well as internal barriers to learning, including psychological and physiological factors, can influence a person's learning experience and ability. Let's dissect these factors in a bit more detail. Environmental factors can include things like interruptions. How well do you learn if your little brother is pestering you as you're studying for an exam? That sort of ties in with a lack of privacy, another barrier to learning. When people are constantly looking over their shoulders, it's going to make them uncomfortable. Sociocultural factors include language barriers. If you're educating a foreign patient that doesn't really understand English very well, they might be willing to learn but simply won't be able to. Other sociocultural barriers include a person's value system. Some cultures may not value advice from a particular person or about a particular topic. A person's educational background is an important barrier to learning as well. If you're educating a person with a PhD in the sciences, you'll be able to talk with them on a different level than someone who hasn't completed high school. Internal barriers include psychological and physiological factors. Psychological barriers include things like fear, anger, anxiety, and depression. If you can think back to the last time you experienced any of these, such as anger, I think you'd agree learning anything during those moments was pretty hard. I think the famous phrases, "don't teach me" or "don't tell me what to do" are uttered sort of appropriately when someone is angry, no? That's because people are not in a proper state of mind to take in valuable lessons in such states of mind. Physiological barriers to learning include fatigue, pain, and sensory deprivation. When we're really tired or in a lot of pain, the last thing we are concerned about is assimilating new information. If a person has sensory deprivation, such as poor hearing, that can significantly impede their learning abilities. When learning does occur, assuming all barriers or as many as possible have been removed or circumvented, then learning will occur in 3 domains: the cognitive domain, the psychomotor domain, and the affective domain. As an educator, you will need to ensure that the lesson plans you develop tap into all 3 to maximize learning. The cognitive domain refers to intellectual understanding, facts, and problem solving. An example of this may be having patients repeat the names of the medications they are taking, what their purposes are, and the major side effects they must look out for. The next domain is the psychomotor domain, which refers to learning based on motor skills and the practical and physical application of theoretical knowledge. Working off of our prior example, let's say the medication the person learned about is insulin. Learning how to administer an insulin injection would fall into the psychomotor domain of learning in this case. Finally, there's the affective domain, learning based on changing a person's belief, emotions, and attitudes so they can make better judgments. Again, going off of our example here, a client accepting that she has a lifelong disease, diabetes in this case, and understanding that it doesn't define her as a person, would fall into the affective domain. Let's summarize everything we learned. The 2 major kinds of barriers to learning are external barriers to learning, such as environmental and socio-cultural factors, as well as internal barriers to learning, including psychological and physiological factors. When designing a teaching plan, take note of these potential impediments to learning success, and make sure to develop your plan in such a way that it touches upon the 3 major domains of learning: the cognitive domain, which refers to intellectual understanding, facts, and problem solving; the psychomotor domain, which refers to learning based on motor skills and the practical and physical application of theoretical knowledge; and the affective domain, which is learning based on changing people's beliefs, emotions, and attitudes so they can make better judgments. So you have been tasked today with educating a bunch of tiny tots and older kids. How are you going to do this? Are you going to basically treat them as little versions of adults, or are you going to use specific teaching strategies designed for younger age groups? This lesson is going to go over some key pointers on proper teaching strategies as they relate to infants, toddlers, preschoolers, school-aged children, and adolescents. It's pretty much self-explanatory that a child's readiness and ability to learn will vary with age. Therefore, your strategy should also vary with age and/or the child's developmental level. Age and developmental level do not always go hand in hand, and thus, you must assess both elements separately prior to engaging and learning with the client. Another very important part of teaching children is that when teaching young children, a nurse has to work very closely with the child's caretaker. This means the caretaker needs to learn a lot of pertinent information the child simply may not be able to grasp. When it comes to young children, realize that young children learn largely through play. Thus, the incorporation of play and games to relay an important point will be key with young children. What can you use? Toys, coloring books, videos, dolls, and puppets are all great examples. Children can also be involved directly in play in such a way as to teach them an appropriate skill. For example, you can have a child put a bandage on a doll. When teaching children, make sure to take the following into account as well. Do not use big words with children or their caretakers. Use lots of repetition and positive reinforcement. Make sure your goals are realistic to their age and developmental level. Ensure the child and caregiver have understood the information by asking them to repeat what they have learned. Encourage the caregiver to participate in the activity even if it seems silly. When it comes to teaching older children, that is to say adolescents, things change a bit because older children become opinionated and more independent. They develop the ability to conceptualize complex relationships better, and so on. Adolescents should be taught in group sessions in addition to any necessary individual sessions because peer support can strongly influence their learning experience. When teaching adolescents, nurses should also be aware of any negative peer pressure influencing the child's learning experience. Ask an adolescent's opinion. This shows respect and allows for bonding. Identify the adolescent's positive qualities and use that as a stepping stone to build upon. Encourage older children to engage in problem-solving activities so they can gain confidence and independence in their decision-making abilities as they enter adulthood. All of these things are just some of the very general strategies and nuances that must be taken into account when teaching younger and older children. In this last section, why don't we look at some more things we can do and to what end? When tasked with educating infants, nurses should focus on the caregivers and teach by role-playing important behaviors. The caregivers should be taught proper nutrition, sleep patterns, how to deal with diaper rations, so forth. With toddlers and preschoolers, comfort toys or blankets, stickers, dolls, videos, and even simple and safe medical equipment can be used to teach the child important concepts. Remember, play is important for these kids. Parents should be included so as to decrease the child's level of anxiety around unfamiliar settings and people. Important concepts to relay to the children and their caregivers at this stage include the need for good dental care, vaccination, and nutrition. School-aged children can use toys, books, role-play exercises, and computer games to learn about safety, basic hygiene, as well as how to properly socialize with their peers. Adolescents can be given reading material and engage in role-play and demonstrations to learn about topics related to sexuality, substance abuse, sports injuries, physiologic changes related to puberty, and so on. Remember, kids are not small adults. They do not process information the same way as mom and dad. This means teaching strategies must be custom tailored to a child's age and developmental level. When teaching young children, a nurse has to work very closely with the child's caretaker and use lots of play-based activities. Keep these other things in mind as well. Do not use big words with children or their caretakers. Use lots of repetition and positive reinforcement. Make sure your goals are realistic to their age and developmental level. Ensure the child and caregiver have understood the information by asking them to repeat what they have learned, and encourage the caregiver to participate in the activity, even if it seems silly. With respect to adolescents, don't forget that adolescents should be taught in group sessions as peer support is important in this stage of life. But be aware of any negative peer pressure influencing the child's learning experience. Ask an adolescent's opinion. Identify the adolescent's positive qualities and use that as a stepping stone to build upon. And encourage older children to engage in problem-solving activities so they can gain confidence and independence in their decision-making abilities as they enter adulthood. Although an adult is an adult, there are different categories of adults. There's young adults, middle-aged adults, and older adults. A lot of the factors and strategies involved in educating adults about their health are the same, but there are some important differences. You, as a nurse, will need to keep these differences in mind when educating your client about topics related to these different groups. 4 main strategies can be used when teaching adults of all ages. These include the use of discussion, demonstration, role play, and printed material. But specifically, when it comes to young adults, the content that's chosen for any of these strategies needs to be relevant or you'll lose them quick. Presenting information about dementia to a young adult is usually not very relevant, but information regarding things like contraception or parenting skills may be. Other topics that are pertinent to this age category include nutrition. What kinds of nutrition? Why is it important? What are the benefits of appropriate nutrition and consequences of eating junk food? Exercise. What kinds of exercise should they engage in? How much? Why? Time management. Why is it important to balance work and life? Stress management. What are the psychological and physiological implications of stress? What about long-term effects? The strategies used to teach young adults are basically the same exact ones for middle-aged adults. However, the topics may need to be altered a bit. For example, middle-aged adults may need to recognize they need to make important lifestyle changes now, as time is of the essence before they get a chronic illness. This may include important topics such as weight loss and strategies for accomplishing weight loss goals. Middle-aged adults should be made aware that as they age, they become more and more vulnerable to all sorts of illnesses and injuries. This includes pneumonia, cancer, and chronic endocrine diseases. Besides learning about appropriate lifestyle modification involving nutrition and exercises, middle-aged adults also need to learn about stress management as well as key warning signs of possible impending illnesses. For example, they may need to learn about how to spot memory problems, signs of cancer like a change in the color of a mole, or an endocrine disease such as sudden weight gain, so that all can be caught and treated earlier. When educating older adults, you can use the same strategies as those with young and middle-aged adults, with one important distinction. Older adults are far more likely to have problems with reading or sensory perceptual changes. Thus, their vision, hearing, and even sense of touch, pain, and ability to grasp objects or sense their body's position in space need to be assessed prior to developing an appropriate teaching plan. An older adult is more likely to suffer from diseases and conditions such as arthritis that may limit their ability to engage in certain role-playing activities or demonstrations. Other important things to consider for older adults is the need for large print material if using printed material for learning. Older adults, despite potential health concerns, often want to remain as independent as possible, and it will be your job as a nurse to explain the choices they have with respect to independence. These choices can include the use of technology, specific physiotherapy to improve their independence, and so forth. Additionally, things older adults may need to learn about include information about the diseases they have or may be at risk of developing, information on how to deal with loss and grief, stress management, proper socialization skills because older adults are at risk of being secluded from society, and elimination patterns related to incontinence. When teaching older adults this information, allow for periods of silence to allow them time to process information. Use this time to allow them to reflect on sensitive topics such as loss and grief. Because older adults are more likely to have sensory losses, use as many different visual and auditory stimuli as possible at the same time in order to increase the chances material will be retained. By no means did we cover all of the strategies and nuances between different adult age groups. However, you should now have a very good grasp of the importance of tailoring your content and teaching strategies to the specific group of adults you are dealing with. Regardless of the age group, 4 main teaching strategies should be used with all adults. They are discussion, demonstration, role play, and printed material. All adult age groups will have generally different needs. Young adults will be more interested in learning topics relevant to them, like parenting skills. Middle-aged adults will need to learn about lifestyle changes they need to make to improve the quality of their older years. And older adults will need to learn about topics related to grief and loss, as well as the diseases they are suffering from. Don't forget that older adults may have special needs that should be taken into account when designing learning strategies for them. This may include mobility issues and sensory losses you'll need to assess for and adapt to. As a nurse, you will come across a wide swath of patients you'll need to educate. They will vary based by race, gender, beliefs, culture, and language. They will also vary based on special needs. Some people you educate will be essentially of sound body and mind. Others will have serious disadvantages. They may have sensory impairments. They may have a chronic illness. They may have a developmental delay or poor literacy skills. These scenarios pose additional challenges that must be overcome with different kinds of strategies. Let's go over some of them. A person is considered to have an intellectual disability, formerly called mental retardation, if they have an IQ score of less than 70. There are different severities of intellectual disabilities, and thus your teaching strategies will need to vary based on this. For instance, you will be able to educate a person with a mild intellectual disability relatively effectively by discussing simple topics in simple ways. This means no big words. Additionally, you'll need to use very straightforward sentences and a concrete language to get your point across. There may not be much room for nuance, subtlety, and double meanings in such a discussion. Games will also be beneficial in educating and engaging such clientele, and repetition will be critical in reinforcing the points you need to get across. On the other hand, people who have a profound intellectual disability cannot truly learn in the traditional sense of the word. Instead, you'll have to communicate frequently and repetitively with clients who are profoundly intellectually disabled. People who have poor literacy skills have their own unique sets of challenges. When it comes to health literacy goes beyond traditional reading skills. Health literacy involves reading skills, reading comprehension, healthcare decision-making skills, and basic math skills. It has been shown that people with low health literacy are more likely to have a poor health status. This means it will be of utmost importance that you assess health literacy in a client of yours prior to beginning a teaching plan, because the majority of your teaching material is likely to be in printed form, even though about 1/3 of the population in the U.S. has some form of poor health literacy. Strategies for teaching people with low health literacy levels include using very simple words, using lots of examples, and giving very clear definitions. Clients who have chronic illnesses of a long duration, have their own concerns that may impede their learning. For instance, a person who has arthritis may find it very painful or difficult to move during a role-playing exercise or a demonstration of some sort. Individuals with a chronic illness like diabetes must be assessed as to their understanding of self-care as the disease, their body's response to it, and their medication changes over time. People who may have a chronic problem such as high blood pressure need to be constantly updated as to how the medication they are taking is helping them now and how it will help them in the future. High blood pressure is known as the silent killer because it rarely causes any overt signs and symptoms, despite insidiously causing great harm to the body's tissues and organs over time. This is one reason why some people decide to stop taking their medication. They just don't feel or see the need for it if no signs or symptoms are currently present. It will be your job to educate such patients on an ongoing basis, to remind them that they are taking the medication to stop things like serious heart problems or kidney disease, which the high blood pressure will eventually bring about if not taken care of today. Clients of yours that have sensory impairments will also necessitate adjustments to your teaching plan. These sensory impairments can arise as a result of an illness like diabetes or an injury from a car accident, or simply due to the degenerative changes associated with aging. Here are some key principles you should use with patients who have different types of sensory impairments. If a client has a memory impairment, use repetition and lots of different cues. The cues can be pictures, symbols, written words, and spoken words. Clients that are visually impaired should be provided with large print materials, appropriate eyeglasses or magnifying glasses, as well as adequate lighting, especially lighting that reduces glare. Hearing impaired patients should be faced directly when spoken to. You should use short sentences as well as words that are easily understood with them. When talking to the hearing impaired patient, make sure there is no distracting noise around. Further enforce any concept you are verbally relaying with gestures or demonstrations that visually relay the information you may have trouble getting across through auditory stimuli. And you thought the medical part of nursing care was complex. Patient education, especially when considering patients with special needs, is quite complex on its own as well. For instance, clients with an intellectual disability or mental retardation have an IQ score of less than 70, and they will benefit from lots of repetition and direct, concrete language. Individuals with poor health literacy, poor reading skills, reading comprehension, healthcare decision-making skills, and basic math skills should get lots of examples and definitions during their education. Clients with a chronic illness, an illness of a long duration, need to be updated on an ongoing basis as to the factors affecting their disease and body. Patients with sensory impairments, such as hearing loss, need additional cues, like visual ones, in order to better understand the points you are trying to get across.
The goal at the beginning of a patient's stay at the hospital is to get the patient well enough to get out of the hospital. This goal is a concerted effort among the entire healthcare team that takes care of the patient from the point of admission. The final decision for patient discharge, or the release of a patient from the hospital, is made by the attending physician responsible for the patient. There are often many different concerns that must be addressed in order to make sure the patient is safely discharged and to reach the goal of minimizing the chance that the patient will have to be readmitted for the same or a related condition again within a short time frame. The overall discharge process is the same for each patient, but the details may be very different depending upon the patient's overall health condition, living situation, and other circumstances. Let's see how the patient discharge planning process works. One of the responsibilities that you may have as a nurse is to plan every aspect of a patient being discharged from the hospital. Discharge planning involves knowing the physician's orders for the patient, which will detail everything that needs to happen with patients once they are discharged. The orders are essentially your guidelines for the discharge. The first thing to plan is the destination for the patient after discharge. The physician may discharge the patient to go home or to a nursing facility, rehabilitation center, or some form of a group home. The patient's own home is usually the easiest destination since they already have space there. Placing the patient in any of the other facilities means that you need to contact the facility and make sure they have a bed available. In addition to securing a bed for the patient, you must verify that the facility accepts the insurance under which the patient is covered. The next step in discharge planning is sending the physician's orders over to the facility, caregiver, and/or family. It is important to verify that all the requirements for the patient will be able to be met when the patient is discharged. Medication orders should be communicated at this point, and caregivers should determine which ones need to be ordered from a pharmacy and delivered, and which ones are available at the facility or home already. Once you have confirmed a spot for the patient and they have the doctor's orders, you need to arrange transport for the patient to the facility. Transport options may include patients transporting themselves, family transporting the patient, or transport using an ambulatory service. The type of transport will depend on the status of the patient and any required equipment to sustain the patient's current condition. If transport involves anyone other than just the patient, then you need to schedule the patient pickup. Give the person or company that is picking up the patient the discharge time, discharge location, and a destination for the patient. The insurance information should be given and verified when an ambulatory service is used to ensure they accept the patient's insurance. You always want to be sure that your patients are educated on any conditions or diseases that they were diagnosed with during hospitalization. Patient teaching should include an explanation of any and all diagnoses, the treatment plan including how and when to take medications, possible side effects of treatments, follow-up appointments, and any signs and symptoms for which they should seek immediate medical care. Patient teaching is an important part of the discharge process since it will increase the likelihood of the patient not being admitted again. Once everything has been set up and explained, make sure the patient, caregiver, or healthcare proxy signs the discharge instruction information sheet. Their signature documents that they received the instructions from the doctor on what should happen after they leave the hospital. We had a chance to see everything that goes into the discharge planning portion of the discharge process. Patient discharge means to release a patient from the hospital. Let's do a quick glance back at what we discussed today. The first thing to plan is a destination for the patient after discharge. Destinations may include home, nursing facilities, rehabilitation centers, or group homes. The next step is to send the physician's orders over to the facility, caregiver, and/or family. It is important to verify that all the requirements for the patient will be able to be met when the patient is discharged. The third step is to arrange transport for the patient to the destination. Transport options may include patients transporting themselves, family transporting the patient, or transport using an ambulatory service. Patient teaching is the next part of the discharge planning. Patient teaching should include everything about the diagnosis and treatment plan, as well as what to look out for that could require medical attention. The last part of the discharge planning is to make sure the patient, caregiver, or healthcare proxy signs the discharge instructions information sheet. Whenever a patient is admitted to the hospital, everyone has one focus and concern. The focus is successful patient discharge, or the release of a patient from the hospital. You and the rest of the healthcare team are going to meet this focus through discharge planning, which is a plan of action to address the needs of the patient in the hospital setting and after discharge. During the process of discharge planning, you want to ensure that you as a nurse and other healthcare workers are thorough enough to decrease the likelihood of the patient being readmitted to the hospital for anything related to the current hospital visit. You need to know and think about the potential risk factors for readmission as you are doing discharge planning. Let's review those risk factors now by looking at what is going on with our patient, Will. Arguably, the most common risk factor for readmission is premature discharge and/or inadequate support following discharge. This risk factor has to do with the patient being released from the hospital before reaching an acceptable point in treatment or health status. This could happen to Will if he isn't fully assessed prior to discharge. Failing to recognize a potential future need may cause Will to have inadequate support after discharge. A separate but related risk factor is when a patient is discharged against medical advice. Will leads a very busy life and just wants to leave the hospital or refuse the treatment at the hospital. This is a huge risk factor in that the healthcare team realizes that Will is not up to a certain health status. There is a very good likelihood that the patient will return in a very short period of time for the same health concern or one that is more complicated due to failing to receive treatment sooner. Another risk factor, insufficient follow-up after discharge, is one that you yourself may have experienced. Have you ever been told to make an appointment with your PCP about a week after being discharged from the hospital, but you didn't go because you felt better and didn't think there was a need to go? Patients do this all the time, and it puts them at risk. This risk factor could be the fault of multiple parties. The hospital team could be responsible if information was not successfully communicated to Will regarding his need for a follow-up appointment with a primary care physician, PCP. Responsibility could fall on Will if he simply doesn't go to the follow-up appointment. It could be the fault of Will's caregiver if he or she fails to take Will to the follow-up appointments. Errors in treatment therapy is another risk factor that occurs frequently, resulting in patients coming back to the hospital. The biggest treatment therapy culprit associated with hospital readmission is medication. Will may experience side effects from the new medication that require medical attention. He could also overdose on the medications due to not understanding how to take new medications or by having more than one prescription for the same medication. His caregivers may have also failed to give him the prescriptions he needs to get his medications. This risk factor has implications beyond just readmission, since incorrect administration of medication can potentially lead to Will's death. Failure to communicate details of the hospitalization to the patient's PCP is another rather common cause for hospital readmission. The biggest problem in this area is usually the lack of communication about tests and results that were run during the hospitalization. This can potentially cause needed treatments to not be rendered or to be repeated, which can cause the patient to be readmitted, be disabled, or die. For example, let's say that Will was in the hospital and the attending physician ordered tests to check for blood clots. Before the test results were received, Will is discharged from the hospital. The test results come back positive for blood clots. If the PCP is not aware of this, then Will would not get the needed treatment. If he doesn't get treatment, then a clot could reach his brain, resulting in a stroke and possibly death. Patients may experience complications after procedures that were done during the hospital stay. Some complications could be so severe that they require medical attention and present a risk factor for Will returning to the hospital. This particular risk factor is another one that could result in Will's death. Some potential complications to procedures are internal bleeding and improper healing. The last category of risk factors has to do with situations that may come up prior to Will's discharge. Hospital-acquired infections, patient falls, and bed sores could result in hospital readmission. Here's what this may look like. Our patient Will is in the hospital due to having a heart attack, but contracts pneumonia while in the hospital. The symptoms may not really show up until after discharge, and the healthcare team isn't looking for pneumonia since it has nothing to do with the heart attack. Will ends up back in the hospital 4 days later with an active case of pneumonia. We took a pretty in-depth look at the most common risk factors surrounding patient discharge. Patient discharge is the release of a patient from the hospital. We know that patient discharge is based on discharge planning, which is a plan of action to address the needs of the patient in the hospital setting and after discharge. Here's a recap of the risk factors that we identified in this lesson. Premature discharge and/or inadequate support following discharge, which is discharging a patient before they reach a certain health status. Patient is discharged against medical advice, which is when patients refuse treatment and decide to leave the hospital against the advice of the medical team. Insufficient follow-up after discharge, such as not going for follow-up appointments. Errors in treatment therapy, such as errors in the administration of medications. Failure to communicate details of the hospitalization to the patient's PCP, such as tests and test results. Complications after procedures, such as internal bleeding and improper healing. Hospital-acquired infections, patient falls, and bed sores, especially those that show symptoms after patient discharge.